Welcome to the Deep Dive. This is the show where we really get into the weeds on big, complex topics. We're not just scratching the surface. We're here to pull out the most crucial insights, the real gems of knowledge.
Exactly.
And today, our mission really is to help you achieve mastery over a subject that, let's face it, often feels pretty dense. The pharmacology of psychosis and mania. Imagine getting all that vital info, all the critical stuff about these major mental health areas, just distilled, clarified, making you feel genuinely well-informed, like at the top professionals in this field.
That's absolutely the goal. Because we're not just listing drug names here.
No.
We're diving deep into our source material, GOODMAN and GILMAN's The Pharmacology, a really core text to understand how these conditions actually work at a deep level.
Yeah.
Why certain treatments are effective, the science behind them, what's cutting edge, and what we still don't know. It's about unpacking those intricate details so you can connect the dots, really gain that specialist level clarity.
Absolutely. Consider this your personal deep dive. We want to trigger those aha moments, help you cut through all the noise, the information overload, and truly grasp the sophisticated science behind these critical treatments. So let's peel back those layers. Okay, let's start right at the beginning. We hear psychosis thrown around a lot. But what does it actually mean clinically? What are we really talking about here?
Right. Well, fundamentally, psychosis isn't really a diagnosis on its own.
Okay.
It's more of a key symptom, a sign, really. It pops up in numerous psychiatric illnesses. And essentially, it's marked by a really profound distortion or sometimes even a complete break from reality.
Wow.
Yeah, so this can show up in different ways, maybe altered perceptions or severely disorganized behavior or speech. It's basically a state where someone's thoughts and perceptions are impaired to the point where they really struggle to know what's real and what isn't.
And we often hear about positive symptoms in this context. Can you break down what those are and why positive? It sounds a bit counterintuitive.
Yeah, that terminology throws people sometimes. Positive here doesn't mean good.
Right.
It means something is added to a person's typical experience. Things are present that shouldn't be there. The common ones you'll see are hallucinations. So sensory experiences without any real external stimulus. Seeing things, hearing voices, auditory hallucinations are very common, smelling things, even feeling things that aren't there.
Okay.
Then there are delusions. These are fixed, false beliefs held with, absolute conviction, even when there's clear evidence against them. You can't reason someone out of delusion. They might believe they're being persecuted or have special powers or that their thoughts are being controlled.
Okay.
Disorganized speech is another. This reflects a breakdown in thought processes. Speech might be rambling, hard to follow, jumping between topics, or just nonsensical.
Right.
And finally, disorganized or agitated behavior. This can range from, odd mannerisms or inappropriate emotional responses to extreme restlessness or agitation.
Oh, I see.
And what's really key here is that these positive symptoms, they can appear alone or together across all the psychotic disorders.
Yeah.
And importantly, they tend to be the most responsive to medication.
Okay, so it's a common symptom across a range of conditions, not just one illness. That must mean the underlying causes, the etiologies are really diverse, right? And need different approaches.
You've hit a crucial point there.
Yeah.
While the symptoms might look similar on the surface, what's driving them can be very different. Psychosis can be part of. Mood disorders like major depression or mania when they get severe.
Okay.
Substance-induced psychosis from drugs or alcohol, intoxication or withdrawal.
Right.
Dementia with psychotic features that happens in neurodegenerative diseases.
Yeah.
Delirium with psychotic features. That's more of an acute confusion state, often triggered by medical issues.
Okay.
Brief psychotic disorder, which is, like it sounds, sudden and short-lived. Delusional disorder, where it's mainly just persistent delusions. Schizoaffective disorders, which kind of blend mood disorder and schizophrenia symptoms.
Okay.
And then, of course, schizophrenia itself, often seen as the sort of prototype because it's chronic and the symptoms are so profound.
Got it.
And yeah, each one needs a really unique treatment strategy because you have to address the root cause, not just the psychosis symptom.
Okay, since schizophrenia is often seen as that prototypic disorder, let's zoom in there. What do we know about how common it is globally and what really sets it apart beyond just those positive symptoms?
Yeah, the prevalence story is interesting. For a long time, older textbooks usually said about 1% of the population.
I remember seeing that figure.
Right. But more recent, really high-quality research has kind of refined that. There was a big meta-analysis in 2018, looked at over 100 studies, and it found that, interestingly, Higher quality studies actually tended to find lower prevalence estimates.
Oh, interesting.
Yeah. So the global point prevalence, that's the rate at one specific time, claimed to have held pretty steady at about 0.28% between 1990 and 2016.
Okay, 0.28%.
Yeah. But, and this is the important part, because the world's population grew so much during that time,
Right.
the actual number of people affected by schizophrenia still went up by nearly 60%.
Wow. So the rate is stable, but the total number affected has increased significantly just due to population growth.
Exactly. It's a crucial distinction.
Okay, that clarifies the numbers, but clinically, what makes schizophrenia different? What else is going on besides the hallucinations and delusions?
Right. This is where it gets more complex and, frankly, more challenging to treat. While those positive symptoms are common across psychoses and often respond pretty well to meds, schizophrenia patients also grapple with two other major symptom groups. Negative symptoms.
Yeah.
These are about a deficit or an absence of normal functions. They're often really debilitating.
Okay.
Things like apathy, just a lack of interest. Avolition, which is a huge decreased motivation, finding it hard to start or stick with anything.
Yeah.
Diminished expression, like a flat affect. Reduced emotion, talking less. And reduced social drive, just less interest in connecting with people.
That sounds incredibly difficult to live with.
It really is. And then there are the cognitive deficits. These are problems with attention, memory, executive functions, planning, problem solving, and just processing speed.
Right.
And these negative and cognitive symptoms, they're what really distinguish schizophrenia. And unfortunately, they're much, much less responsive to our current medications compared to the positive symptoms. It's a huge unmet need in treatment.
That really gives a much fuller, clearer picture of just how profoundly schizophrenia can affect someone. Okay, let's shift to the brain chemistry. What's the neurotransmitter situation in psychosis? How do these chemical messengers get disrupted?
Well, it's incredibly complex neuroscience, really, like a whole orchestra playing out of tune. Psychosis isn't just one chemical going wrong.
Right.
Research points to dysfunction across multiple key neurotransmitter systems. We're talking cholinergic, glutamatergic, serotonergic, GABAergic, and the big one, dopaminergic systems.
So multiple players involved, but dopamine often gets the spotlight, historically and even now. Can you explain its central role?
Absolutely. Dopamine is central, no question. And its discovery was, well, transformative. Over 60 years ago, Arvid Carlsson made this incredible deduction. He noticed that the early antipsychotics, drugs like haloperidol and chlorpromazine, had both therapeutic effects and side effects that looked like Parkinson's disease.
Right, Parkinsonism.
Exactly. And he figured out that both the good effects and the bad effects seemed to stem from the same thing. These drugs were blocking dopamine receptors, specifically the D2 type, in the brain. So that led him to hypothesize that maybe psychosis, particularly those positive symptoms, was caused by too much dopamine activity.
And that hypothesis basically kicked off a whole new era of drug development, didn't it?
It fundamentally changed psychopharmacology.
Yeah.
Carlson's insight directly led to the first-generation antipsychotics, the FGAs, and later many of the second-generation ones, the SGAs. They all primarily work by fiddling with the D2 dopamine receptors, either blocking them outright or, with newer ones, acting as partial agonists. And what's really powerful now is that this isn't just a hypothesis anymore.
Right.
It's established fact. We have brain imaging techniques, PET scans, SPECT scans, that let us look directly. And these studies show a clear link between how severe the positive symptoms are and how much excess D2-mediated dopamine activity there is.
Wow.
Specifically, in certain brain areas, the associative striatum and the nearby sensorimotor striatum in schizophrenia patients, we can literally see that giving antipsychotics reduces this dopamine activity, and that reduction lines up with symptoms getting better.
That's incredible, to go from a deduction to actually seeing it in living brains. But is it all about dopamine? Or are we exploring other pathways now, moving beyond that dopamine-centric view?
Oh, definitely not all dopamine. The field is always evolving, always finding new pieces of the puzzle.
Okay.
Take glutamate, for example. We know drugs like PCP and ketamine, which block NMDA glutamate receptors, can cause really intense psychosis-like symptoms.
Right.
So glutamate pathways are clearly involved somehow. But despite that, and a lot of research effort, phase 3 trials for drugs that target glutamate, like glycine reuptake inhibitors or certain metabotropic receptor agonists, they haven't really panned out for schizophrenia treatment yet.
So the potential is there, but we haven't cracked it yet.
Exactly. But given how fundamental glutamate is for brain function, it's still a major focus for drug development. Yeah, the search is definitely on.
Okay, so glutamate's still in play. What about serotonin? How did knowing about drugs like LSD lead to something like pimavanserin?
Right, this is a fantastic example of how understanding different pathways leads to breakthroughs. We knew that potent serotonin 5-HT2A agonists, like LSD, could mimic psychosis.
Mm-hmm.
Then later, research found that psychosis in Parkinson's disease, PDP, seems linked to an upregulation, basically more sensitive receptors of these 5-HT2A receptors in the cortex. Putting those two pieces together led directly to the development and approval of pimavanserin specifically for PDP.
Mm.
And what's truly groundbreaking about pimavanserin is that it's a potent 5-HT2A inverse agonist.
Mm-hmm.
It basically shuts down that receptor's activity.
Mm-hmm.
But crucially, it has zero dopamine binding.
Wow, none at all.
None. Which completely blew apart the old dogma. It showed you can treat psychosis effectively, at least in Parkinson's, without touching dopamine receptors. It was a real paradigm shift.
That is a huge deal. Are there even newer targets emerging beyond serotonin?
Absolutely. The field keeps moving. For example, researchers noticed that mice genetically engineered to lack muscarinic M4 receptors showed psychosis-like behaviors.
Okay.
That spurred human trials of a drug called xanomeline, which is an M4 and M1 agonist. And a positive phase 2 study came out in 2021. So that suggests a totally different pathway again.
Interesting.
And even more recently, there's a lot of excitement around trace amine-associated receptor 1, TAR1 agonists. Early human data looks promising for schizophrenia. These could genuinely rewrite the textbooks again, showing that direct D2 binding might not be the only game in town for effective antipsychotics. It's a really dynamic area.
Okay, we've really unpacked psychosis and the complex brain chemistry. Now let's pivot to the treatments themselves, the antipsychotics. Can you walk us through the intricate ways these drugs work at the D2 receptor level? How do they actually affect the brain cells?
Right. So it gets down to the molecular level here. All the dopamine receptors, D1 through D5, are what we call G-protein-coupled receptors, or GPCRs. Think of them like little docking stations on a cell surface.
Okay.
When dopamine, or a drug, binds to one, it flips a switch inside the cell, activating a G protein.
Got it.
Now, D2, D3, and D4 receptors specifically link up with an inhibitory G protein called G. When G gets activated, it reduces the production of cyclic AMP, which is a key signaling molecule inside the cell. So it basically tells the cell to calm down.
Okay, dampens the signal.
Exactly. Whereas D1 and D5 receptors link to a stimulatory G protein, GS, which increases cyclic AMP and ramps up cell activity.
Right.
And beyond just cyclic AMP, activating G can also directly open potassium channels. That lets potassium flow out, making the inside of the cell more negative, hyperpolarizing it,
Right.
which makes it harder for the neuron to fire off an electrical signal.
So multiple ways to turn down the volume, essentially. But I also read about actions beyond just these G proteins, something about non-G protein pathways. What's that about?
Yeah, this is where the cutting-edge understanding gets even more nuanced. The effects of antipsychotics at D2 receptors aren't just through those classic GPCR pathways.
Okay.
They also involve a non-G protein pathway. Specifically, they modulate an enzyme called glycogen synthase kinase 3 beta, or GSK3 beta.
GSK3 beta.
Right. And this happens through a signaling complex involving something called beta-arrestin 2, PKB, and PP2A. It's a whole cascade. And what's interesting is that the second-generation antipsychotics, the SGAs, seem to block these D2 receptor beta-arrestin 2 interactions more strongly than the first-generation ones, the FGAs. FGAs tend to hit both pathways more equally.
Huh.
So this adds another layer to how these drugs work and potentially why their side effect profiles might differ.
That's incredibly detailed molecular action. Given all this complexity, do antipsychotics actually help with the cognitive problems we talked about in schizophrenia?
That's a really important question, and the answer is, well, mostly no, unfortunately.
Oh.
While antipsychotics can reverse the cognitive disruption you might see if you give someone, say, ketamine temporarily,
Right.
they don't really do much to fix the deep-seated chronic cognitive problems in schizophrenia itself. Those issues are thought to be linked more to problems with D1 signaling in the cortex, which is a different beast than the D2 signaling we've been focusing on for positive symptoms.
So different dopamine pathways involved.
Exactly. But there is some hope on the horizon. There are experimental drugs being developed called beta-arrestin 2 biased D2 partial agonists.
Okay.
These are really interesting because they don't rely so much on the traditional G protein signaling. They seem to have this unique profile where they still provide D2 antagonism in the striatum, which is what you need for the antipsychotic effect on positive symptoms, but they also act as agonists in the cortex.
Ah.
Yeah, and this cortical agonism seems to boost the activity of certain neurons called fast-spiking interneurons, which are really important for cognitive processes.
So potentially tackling both positive symptoms and cognition. That would be huge.
It would be a massive step forward if these pan out in further trials. It's a very active area of research.
Okay, let's really nail down the difference between straight D2 antagonism and this partial agonism. You mentioned figure 19-2 in the source material illustrates this well. Can you break that down for us? It feels like a core concept for mastering this.
Absolutely fundamental. Let's clarify the two main approaches. D2 antagonism. This is the classic mechanism for the FGAs and many SGAs.
Yeah.
Think of the D2 receptor like a parking spot for dopamine.
Okay.
An antagonist is like putting a big solid block in that spot. Dopamine just can't park there, can't send its signal. To get the desired antipsychotic effect, you need to block roughly 60% to 80% of these D2 spots in the striatum.
Right.
But here's the catch. If you block too many, say over 78% or 80%, the risk of those movement side effects, the EPS, goes way up. It's a really fine therapeutic window.
Like a switch you can turn down too far.
Exactly. Now, partial agonism. This is what drugs like aripiprazole, brexpiprazole, and cariprazine do. Instead of a solid block, think of a partial agonist as more like a dimmer switch that has its own built-in low level of light.
Okay.
It occupies the parking spot, blocking the full-strength dopamine signal just like an antagonist. But it also generates a small signal of its own, maybe 18% to 25% of what dopamine would do.
Ah, I see.
So in brain areas where there's too much dopamine activity, it acts like a blocker, bringing the signal down. But because it provides this low-level on signal, it prevents the system from going completely dark. This allows these drugs to occupy a much higher percentage of receptors, often 80% to 100%, without triggering those severe EPS side effects. It's a balancing act.
That's a fantastic analogy. It really clarifies how they can block the excess signal without causing the same level of movement problems. And then there's clozapine. It always seems to be the exception, the unique one. How does its mechanism fit in?
Clozapine really is in a class by itself. Its D2 antagonism is actually quite a bit weaker than many other antipsychotics.
Actually weaker. Okay.
Yeah. What seems to give it its unique power, especially for treatment-resistant schizophrenia where nothing else works, is its very potent blockade of serotonin 5-HT2A receptors, combined with activity at a whole host of other receptors.
Like what?
It hits various muscarinic receptors. It activates NMDA receptors through a glycine site. It even activates that TAR1 receptor we mentioned earlier.
Wow, it's doing a lot.
It really is.
Yeah.
This broad-spectrum action, hitting multiple systems simultaneously, it's thought to be why it works when others fail, and also why it has a lower risk of EPS, despite its other, significant side effect challenges.
Okay, so the mechanisms are clearly more complex than just dopamine blockade or partial agonism. And this deeper understanding must mean our view of psychosis and how we treat it has broadened beyond just schizophrenia, right?
Absolutely. That's a critical takeaway.
Yeah.
Not all psychosis is schizophrenia.
Yeah.
And understanding the difference is vital for choosing the right treatment. The success of pimavanserin for Parkinson's psychosis, remember, no dopamine activity is the perfect example.
Right.
It proves that what works for schizophrenia might not be relevant, or even the best approach, for psychosis caused by something else.
So even within schizophrenia, while dopamine is still key, our understanding of where in the brain the problem lies has become more precise too.
Exactly. Early on, people talked broadly about too much dopamine in the mesolimbic pathway. But now, with better imaging, we can pinpoint it much more accurately. The dopamine dysfunction linked to positive symptoms in schizophrenia seems really localized to the associative striatum and the adjacent sensorimotor striatum. Knowing the precise location helps refine our understanding and, hopefully, future treatments.
And what about psychosis in conditions like delirium or dementia? How do their causes differ, and why does that matter so much for treatment?
Yeah, this is crucial for practical application. The psychosis you see in delirium or dementia, especially Alzheimer's type, often stems from different issues. It could be cholinergic problems, a lack of acetylcholine, maybe due to meds blocking it, or just neuron loss from the disease itself.
Okay.
Or like in Parkinson's, it could be excessive serotonin, 5-HT2A activity in the cortex.
Right.
And for delirium specifically, that acute fluctuating confusion, there are tons of potential triggers you have to hunt down and treat besides just managing the psychosis.
Like infections or medication side effects.
Exactly. Infections, electrolyte imbalances, inflammation, metabolic issues, certain drugs, the list goes on. And the key point is, while antipsychotics might calm the agitation or hallucinations in delirium, they don't fix the underlying problem and they don't shorten the delirium itself. You have to treat the root cause.
That's a really important distinction. So treat the underlying medical issue first. And for Parkinson's disease psychosis, its cause is quite specific too, related to serotonin neuron loss.
Precisely. PDP is strongly linked to the loss of serotonin neurons in the brainstem due to Lewy body pathology. This loss leads to that upregulation, that increased sensitivity of the cortical 5-HT2A receptors.
Ah.
And that specific serotonin-driven mechanism is exactly why pimavanserin, hitting only those 5-HT2A receptors, works so well for that particular condition.
Yeah.
It really drives home how understanding a specific chemistry of a specific psychosis can lead to very targeted non-dopamine treatments.
Okay, given all this variation and complexity, what are the overall goals when using pharmacotherapy for psychosis? Is it just about stopping the positive symptoms, or is there a bigger picture?
There's definitely a distinction between the immediate and long-term aims. The immediate goal, when someone's acutely psychotic, is always to reduce the symptoms causing the most distress or danger. Things like hostility, agitation, severe disorganization. Getting the person calm and safe is priority number one.
Makes sense.
Then, once the crisis is managed, the long-term goal shifts. It becomes about maximizing functional recovery, helping the person get back to their life work, relationships, daily activities.
Right.
This is mostly achieved by keeping those positive symptoms under control. We always hope to improve the negative and cognitive symptoms too, but honestly, the impact of current drugs on those aspects in schizophrenia is pretty modest. So symptom control to improve quality of life remains the primary long-term focus.
So controlling symptoms to enable function. With so many drug options now, how do clinicians actually pick the right one for a specific patient? It sounds complicated.
It is, and it's very individualized. Several things factor into the decision. The underlying condition, obviously schizophrenia needs a different long-term strategy than, say, brief substance-induced psychosis.
Okay.
How acute the situation is, someone highly agitated needs a different immediate approach than someone stable in outpatient care.
Right.
Potential drug interactions, you have to consider everything else the patient is taking. And crucially, the patient's individual sensitivity to side effects. Some people are prone to weight gain, others to sedation, others to movement issues.
Okay.
But here's a key point for you to really master. Aside from a couple of very specific cases, pimavanserin for PDP, clozapine for treatment resistance, we generally cannot predict from the clinical picture which specific antipsychotic someone will respond best to.
Really?
Yeah. So in practice, the choice often boils down to avoiding the side effects the patient is most likely to struggle with based on their history and risk factors. And practical things matter too, like whether a long-acting injectable formulation is available, which can be a lifesaver for adherence.
That's very pragmatic. Okay, let's get into short-term treatment strategies. For those conditions where psychosis is more transient, how are antipsychotics used differently?
Right. For conditions where the psychosis isn't expected to be, chronic, think delirium, dementia-related psychosis, psychosis during major depression or mania, substance-induced psychosis, brief psychotic disorder, the antipsychotic is usually only given during the symptomatic period and maybe for a short while after.
Okay.
Once the underlying cause is treated or the acute episode passes, the antipsychotic is typically tapered off. The duration really varies depending on what caused it and how the patient responds.
Can you give us specifics for delirium, dementia, and Parkinson's psychosis? What are the warnings and special considerations there, especially for older adults?
Yeah, these are vulnerable populations, so you have to be careful. For delirium, you often use very low doses, maybe repeated frequently if needed for agitation. But the really critical thing to remember is the warning as of 2021. Essentially, all antipsychotics carry warnings about increased mortality risk in elderly patients with dementia.
Wow. All of them?
Pretty much. Pimavanserin is the notable exception with a modified warning, acknowledging its specific use case.
Okay.
For delirium, you absolutely want to avoid drugs with anticholinergic effects, as they can make the confusion worse. So you might lean towards high-potency FGAs like haloperidol, which have low anticholinergic activity, or SGAs like risperidone that are also low in that regard. But again, remember, you're just managing symptoms, not fixing the delirium itself.
Right.
For dementia-related psychosis, the big worry is falls. So you really want to avoid causing extrapyramidal symptoms, the movement issues. That means FGAs are generally out. And you'd use modest doses of an SGA, like maybe 0.5 to 1.5 milligrams of risperidone daily to minimize that risk.
So managing symptoms carefully. What about acute mania? Lots of SGAs are approved for that, correct?
Yes, most SGAs are indicated for acute mania. The main exceptions currently being brexpiprazole, clozapine, iloperidone, lumateperone, and lorastone. FDAs work too, but again, That higher EPS risk makes them less attractive generally. The good news for patients in acute mania is that the response is usually pretty quick. You often see improvement in agitation, sleep, delusions, hallucinations within about 7 days, sometimes even starting by day 2. That rapid action is really helpful clinically.
That is fast. And once the mania subsides, for someone with bipolar I, do they typically stay on the antipsychotic long term?
Often, yes, for many months after the acute episode resolves. And usually it's in combination with a mood stabilizer like lithium or valproic acid.
Why the combination?
Because the data clearly shows that combination therapy significantly reduces the risk of manic relapse compared to using either agent alone. It provides better long-term stability. Plus, several antipsychotics are also approved for treating bipolar depression, so continuing the antipsychotic might be needed to manage that side of the illness too. It's about a comprehensive strategy.
Treating both poles and preventing relapse. Got it. What about major depression that has psychotic features? Is that also combination therapy?
Always. For major depression with psychosis, you need both an antidepressant to treat the core depression and an antipsychotic to handle the psychotic symptoms.
Okay.
The antipsychotic doses are usually lower than for schizophrenia or mania, and typically you don't need to continue the antipsychotic long-term once the psychosis clears and the mood improves.
Interesting. So some SGAs actually have antidepressant effects themselves. It's not just about psychosis.
Exactly. This is a really cool area. Some SGAs seem to offer adjunctive antidepressant benefits. Think aripiprazole, brexpiprazole, quetiapine.
Huh.
The mechanisms aren't fully worked out, but it's thought to involve things like blocking certain serotonin receptors, 5-HT7 or 5-HTTC, or maybe acting as a partial agonist at dopamine D3 receptors, or maybe a mix of 5-HT2A antagonism and D1 activation. Blocking 5-HT2C, for instance, can boost dopamine and norepinephrine release, which helps mood, and potent D3 antagonists might block autoreceptors, leading to more D1 activity in the prefrontal cortex. It's complex, but it means some of these drugs have broader utility.
Okay, let's switch to managing acute schizophrenia. What are the immediate goals in that situation, and how are the meds given to get things under control quickly?
Right, in an acute schizophrenia episode, the immediate goals are all about stabilization and safety. You want to reduce agitation, disorganization, or hostility that could be dangerous. You want to lessen the impact of hallucinations, improve thought organization, and reduce extreme social withdrawal so the person can engage with treatment. Doses might be higher initially than for maintenance, but not always. You usually see significant benefits, especially for agitation, pretty fast, often within an hour or two of getting the medication in.
And how do you get it in if someone is maybe reluctant or very agitated?
Good question. We have options. There are oral dissolving tablets, ODTs, or liquid forms, if someone can't or won't swallow pills.
Okay.
If someone is really agitated and not very cooperative, intramuscular IM injections of ziprasidone or olanzapine work well and quickly. They also have less risk of causing acute dystonia, those sudden muscle spasms, compared to older IM haloperidol.
I also saw something about an inhaled version of loxapine. That sounds incredibly fast.
It is. Inhaled oxapine, usually 10 milligrams, is approved in the U.S. for rapid control of agitation in schizophrenia, or bipolar I. It's unique because you get peak drug levels in the blood in under 2 minutes.
Wow.
Super fast. But there's a rare risk of bronchospasm, so it has to be given in a facility that's equipped to handle serious breathing problems, just in case. Needs careful patient selection and a controlled setting.
Okay. So efficacy-wise in acute schizophrenia, how do the older FGAs stack up against the newer SGAs? You mentioned clozapine as special.
Yeah, this is a core piece of knowledge to master, apart from clozapine, which is uniquely effective for treatment-resistant cases.
Right.
SGAs are generally not more effective than FGAs at reducing acute psychotic symptoms. Their big advantage, and it is significant, is their better neurological side effect profile. Fewer movement problems.
Okay, so tolerability is the main benefit.
Exactly. And that's huge for long-term adherence and quality of life.
What are the specific problems with blocking D2 receptors too much, especially with those high-potency FGAs like haloperidol?
Blocking D2 too aggressively, which often happens with high-potency SGAs, brings several downsides. You get more acute neurological side effects, the muscle rigidity, slowness, tremor, dystonia, akathisia, that awful inner restlessness. It can also slow down thinking, what we call bradiphrenia. And critically, it messes with the brain's reward pathways.
No.
Yeah, patients might feel anhedonia, unable to feel pleasure, or just generally dysphoric, uneasy, and unhappy. That can really kill motivation and make people not want to take the medication.
Yeah, I can imagine. Are the low-potency FGAs like clopramazine still used much?
Less often as first-line choices now. They can be very sedating, which might seem useful initially for agitation,
Right.
but they also hit lots of other receptors: heart histamine H1, muscarinic M1, alpha-1 adrenergic.
So lots of side effects.
Exactly. Lots of sedation from H1 blockade. Significant anticholinergic effects from M1 blockade: dry mouth, blurred vision, constipation, urinary retention, and orthostasis dizziness when standing up from alpha-1 blockade. Plus, there are concerns about QTC prolongation, the heart rhythm issue. So while they might sedate, they come with a lot of baggage that makes them tough to tolerate long term.
Okay, that makes sense. Since schizophrenia often requires long-term treatment, how does that change the thinking around antipsychotic choice, especially regarding those chronic side effects?
Right. For long-term treatment of chronic conditions like schizophrenia or schizoaffective disorder, the decision-making really shifts. The top priorities become avoiding long-term side effects, looking at the patient's past treatment responses, and considering if a long-acting injectable LAI is needed for adherence. With SGAs, the big worries about EPS, and especially tardive dyskinesia, are definitely lower than with FGAs. But it's important to know that TD risk with chronic SGA use is still estimated around 7.2%, even if someone's never taken an FGA.
Still a risk then.
It's still a risk. But the major concern that really came to the forefront with SGAs is the metabolic side effects.
Right, the weight gain, diabetes risk.
Exactly. Significant weight gain, dyslipidemia, especially high triglycerides and problems with glucose and insulin, leading to hyperglycemia and increased risk of type 2 diabetes. Agents like clozapine, olanzapine, and higher doses of quetiapine are the biggest culprits here. They're generally not first-line choices anymore, precisely because of this metabolic burden, unless other drugs haven't worked.
So it's always a trade-off. What about those really tough cases? Treatment-resistant schizophrenia. What's the go-to then?
Yeah, for patients who haven't responded adequately to other antipsychotics, the outlook with standard treatments is pretty bleak. Response rates might be less than 5% for most drugs, maybe 7–9% for olanzapine.
Wow.
This is where clozapine is truly the gold standard. It consistently shows response rates between 40% and 60% in these treatment-resistant situations.
That's a huge difference.
Massive. But getting that response depends heavily on achieving the right plasma levels. The target is usually above 350 nanograms per milliliter. But some people might need levels up to 1,000 ng/ml. And a response usually kicks in within about 17 days of hitting that level.
Okay. But it comes with significant risks, right?
It absolutely does. And this is crucial for anyone managing clozapine to master. It has numerous serious potential side effects that need meticulous management.
Right.
The big ones are severe neutropenia, that dangerous drop in white blood cells, which requires mandatory blood monitoring,
Right.
a very high metabolic burden, major weight gain, lipid problems, diabetes risk,
Right.
risk of myocarditis, heart muscle inflammation, a dose-dependent risk of seizures, tachycardia, and orthostasis, and often really severe constipation, sometimes even bowel obstruction, due to its anticholinergic effects.
That's a serious list.
It is. But for patients where nothing else works, clozapine can be life-changing. Clinicians have to be really skilled at managing these risks. ECT, electroconvulsive therapy, is also an effective option for treatment resistance, often considered alongside or after clozapine.
So, a powerful but demanding drug. Thinking about how these drugs are designed, is it still mostly about the chemical structure, or are the receptor binding details more important now?
The field has definitely shifted.
Yeah.
While old-school structure-function relationships gave us some clues,
Yeah.
detailed receptor binding assays and functional studies are way more informative clinically now. Aripiprazole is a perfect example. Its chemical structure tells you almost nothing about its unique partial agonism at D2 receptors.
Right.
What's really useful is knowing exactly which receptors a drug binds to, how strongly its affinity, and what it does there is an agonist, antagonist, partial agonist, inverse agonist. That tells you much more about both its likely therapeutic effects and its potential side effects. What we still don't fully understand, though, are the precise reasons for clozapine's unique effectiveness, or exactly why some antipsychotics mess with metabolism independently of weight gain, or the exact mechanism behind that increased mortality risk in dementia. Those are still big research questions.
And let's revisit D2 receptor occupancy, the idea that how much drug is bound to the receptor predicts effects. How critical is that concept?
It's absolutely central, especially for the traditional antagonists. Remember, too much dopamine activity in those specific striatal areas is linked to positive symptoms.
Right.
The behavioral effects and the timing of antipsychotic response line up really well with the reduction in D2 activity there. D2 receptor occupancy. The percentage of receptors blocked is a powerful predictor of several things. Clinical efficacy, how well it works, the likelihood of EPS, higher occupancy, higher risk, and the relationship between blood levels and response.
Okay.
Specifically, blocking more than about 78% of D2 receptors in the basal ganglia really ups the risk for EPS, whereas the sweet spot for optimal efficacy with lower EPS risk seems to be in the 60% to 75% range.
Okay. Got it.
And interestingly, most SGAs, except the partial agonists, tend to occupy a much higher percentage of serotonin 5-HT2A receptors at low doses compared to FGAs, often 75–99%. And importantly, because people metabolize drugs so differently due to genetics and environment,
Yeah.
the actual plasma level of the drug is a much better predictor of D2 occupancy in an individual patient than just the dose they're prescribed. This opens the door for more personalized dosing.
That makes perfect sense. Treat the patient based on their levels, not just a standard dose. And what about the role of those other receptors for the atypical antipsychotics? You mentioned atypicality started with clozapine.
Exactly. Clozapine defined atypical because it worked well without causing much EPS, and it strongly blocked those 5-HT2 receptors.
Right.
That 5-HT2A antagonism seems key. It modulates dopamine release, particularly in the prefrontal cortex and basal ganglia, kind of counterbalancing the D2 blockade in the nigrostriatal pathway, which is thought to reduce the EPS risk. And we've seen with pimavanserin and lumateperone that 5-HT2A antagonism alone can have antipsychotic effects, even with little or no D2 occupancy.
Yeah.
And as we mentioned, now we're exploring totally different avenues like muscarinic M4 agonism with its xanomeline and TAAR1 agonism. It really shows the brain's complexity offers multiple ways in to potentially treat psychosis well beyond just hitting D2. It's an exciting time for discovery.
It really is. What about tolerance and dependence? Are antipsychotics addictive like some other drugs?
No, they're definitely not addictive in the typical sense. They don't cause euphoria or compulsive drug seeking.
Okay.
However, patients can develop tolerance to some of the side effects, particularly the sedation from H1 blockade, the orthostasis from alpha-1 blockade, and the anticholinergic effects like dry mouth. That usually happens over days or weeks. There's no good evidence that their actual antipsychotic effectiveness wears off over time with continued use. But interestingly, in animal models, you can demonstrate tolerance to their dopamine receptor effects. And a really important clinical consequence of this adaptation in the dopamine system is the development of postsynaptic dopamine receptor supersensitivity.
Supersensitivity.
Yeah, the brain basically makes the D2 receptors extra sensitive to try and compensate for being blocked chronically. This supersensitivity in the nigrostriatal pathway is thought to be the basis for tardive dyskinesia. And similar changes in the associative striatum might underlie supersensitivity psychosis, where someone's psychosis can worsen dramatically if the antipsychotic is stopped or reduced too quickly.
So the brain's adaptation can cause its own problems down the line. Okay, let's talk ADME absorption, distribution, metabolism, excretion. What are the key things to know about how these drugs travel through the body?
Right, understanding ADME is crucial for practical use. Absorption. For most oral antipsychotics, absorption is pretty good, but there are exceptions like xenopine, fluphenazine, lumateperone, lurasidone. They have low oral bioavailability. The xenopine, for example, was first developed as a sublingual tablet to bypass liver metabolism. If you swallow it, hardly any gets in.
Wow.
Now there's a patch too. For rapid action, IM injections get into the blood within 15–30 minutes, and that inhaled loxapine, as we said, peaks in under 2 minutes.
Okay.
Distribution. They're generally very lipophilic fat-loving, so they easily cross the blood-brain barrier and get into fatty tissues, like the brain. Most are also highly bound to proteins in the blood, mainly alpha-1 glycoproteins. This means they usually don't kick other drugs off their binding sites on albumin, so that type of interaction isn't a huge issue. They do cross the placenta and get into breast milk, which is important for pregnancy and lactation considerations.
Right, and metabolism and excretion.
Even though some have short half-lives in the blood, their biological effects usually last at least 24 hours. That's why once daily dosing works for most, after the initial side effects wear off, they're mostly metabolized by liver enzymes, the CYPs, and they're generally not removed by dialysis. The long-acting injectables are interesting here because they release so slowly, the drug can hang around in the body for months after the last shot. Great for adherence, but something to keep in mind if side effects occur or you need to switch.
Beyond psychosis and mania, what other uses do antipsychotics have? I know they pop up elsewhere.
Yeah, their diverse receptor profiles give them uses in some non-psychotic neurological conditions and even for nausea. For anxiety disorders, some SGAs have shown some benefit as add-ons for OCD, obsessive compulsive disorder,
Okay.
but the evidence isn't super strong across the board, and side effects can be limiting. For PTSD or generalized anxiety, there isn't really strong support for using SGAs routinely.
What about Tourette disorder and detectives?
Yes, their ability to block D2 receptors in the basal ganglia helps suppress toa tics. Aripiprazole is the only one currently FDA approved for Tourette's, usually started at low doses.
Mm.
Older, high-potency FGAs like haloperidol used to be common, but patients without psychosis are really sensitive to the cognitive slowing and anhedonia from dopamine blockade, so they're less favored now. And pimozide is largely out due to heart rhythm concerns.
In Huntington's disease, with its movement issues?
Similar mechanism, D2 blockade in the basal ganglia can reduce the chorea, those involuntary movements. But it's generally not a primary treatment because the risks often outweigh the modest benefits. Drugs that inhibit VMAT2, like tetrabenazine, which reduce dopamine release more gently, are usually preferred now for managing chorea.
More targeted again. Okay, and autism.
Two SGAs, risperidone and aripiprazole, are FDA approved specifically for irritability associated with autism in kids and teens, ages 5 to 16. They're used short-term for severe disruptive behaviors, aggression, or self-injury when behavioral approaches aren't enough. But they don't treat the core symptoms of autism, and kids with intellectual disabilities can be very sensitive to side effects like weight gain and sleepiness.
And finally, antiemetic use for nausea. That seems different.
It does, but it comes back to dopamine blockade again. They block D2 receptors in the chemoreceptor trigger zone in the brainstem, which helps prevent nausea induced by things that stimulate that zone. They don't work as well for nausea originating in the gut or from motion sickness, although some are used for that. Interestingly, common anti-nausea drugs like prochlorperazine and metoclopramide are actually weak dopamine antagonists themselves. Yeah, and even though they don't have much antipsychotic effect at normal anti-nausea doses, they can still cause EPS, akathisia, and even TD if used chronically. They both carry warnings about TD. It really highlights how pervasive the effects of dopamine blockade can be.
Okay, let's shift gears to a really critical area. Adverse effects. This is where the rubber meets the road in terms of real-world impact and why careful monitoring is just so vital. Let's start with the side effects we can largely predict based on how these drugs hit specific monoamine receptors, especially D2, which we know causes EPS and hyperprolactinemia.
Right, and it's pretty direct. The stronger the drug blocks D2 receptors, the higher the likelihood of these effects.
Makes sense.
We're talking acute EPS dystonia, Parkinsonism, akathisia, the severe neuroleptic malignant syndrome, and hyperprolactinemia. As you'd expect, the older FTAs with their potent D2 blockade carry about a 4-fold higher risk of tardive dyskinesia compared to the SGAs.
Okay, so stronger D2 block equals higher risk. Can you walk us through acute dystonia? What does that look like, and when does it usually hit?
Yeah, acute dystonia is these involuntary sustained muscle spasms. It often hits muscles in the tongue, face, neck, or back. It can be really frightening, especially something like an oculogeric crisis, where the eye muscles spasm and the eyes roll up.
Yikes.
Yeah. It typically happens very early within the first few days, sometimes even hours, of starting the drug. Young people, especially those who haven't taken antipsychotics before, are at highest risk because it's such an abrupt drop in dopamine activity for them.
And how do you treat it?
The treatment is usually fast and often confirms the diagnosis. An intramuscular shot of an anti-Parkinsonian agent like diphenhydramine or benztropine. They usually bring dramatic relief very quickly. Diphenhydramine is often given alongside IM haloperidol, prophylactically for this reason, plus it adds sedation.
Okay. And then there's Parkinsonism, which sounds like it mimics Parkinson's disease itself.
It does look very similar. Parkinsonism presents with that classic trio, bradykinesia or slowness of movement, muscle rigidity or stiffness, and often a tremor, usually when resting. Patients might also get that mask-like face, shuffling walk, stooped posture. This tends to show up a bit later than dystonia, maybe 5 to 30 days into treatment. Elderly patients are most at risk because their dopamine systems are already declining with age.
And the treatment.
You try to reduce the antipsychotic dose or switch to a drug with weaker D2 blocking. If that's not enough or not possible, you can add an antiparkinsonian medication. But, and this is a big caveat, especially for older folks, using the anticholinergic antiparkinsonian drugs like benztropine can worsen or cause cognitive problems. So you have to be really careful with those in the elderly.
You mentioned M1 cholinergic receptors before. How do they play into this balance and the treatment of Parkinsonism?
Right, it's an interesting interplay. There are M1 acetylcholine receptors on the same neurons in the striatum that have the D2 receptors. Normally, acetylcholine stimulates these M1 receptors, balancing out dopamine's effect on D2. When you block D2 with an antipsychotic, you disrupt that balance. Adding an M1 antagonist, like benztropine, helps restore the balance by blocking the acetylcholine signal, which reduces the Parkinsonism and dystonia.
Ah, counteracting the imbalance.
Exactly. But, as we said, those M1 blockers come with their own problems. The cognitive effects, dry mouth, constipation, blurred vision, urinary retention. They can even worsen tardive dyskinesia, potentially. That's why, if you need an anti-Parkinsonian drug, amantadine is often preferred. It works differently, boosting dopamine activity a bit without the strong anticholinergic effects.
Okay, good to know. Now, tardive dyskinesia, TD. This is the big one people worry about with long-term use. What's the mechanism behind it and who's most at risk?
Yeah, TD is a major concern. It's a late-onset movement disorder, usually showing up after months or years of treatment. The thinking is that it's caused by the brain adapting to chronic D2 blockade by making the postsynaptic D2 receptors supersensitive.
Right, that's supersensitivity again.
Exactly. The brain's trying to overcome the blockade. Elderly patients are at much higher risk, about 5 times more likely to develop it than younger folks. People with mood disorders might also be slightly more susceptible than those with schizophrenia. And while the risk is highest with FGAs, maybe 25% after a year, it's still significant with SGAs, around 7.2%, even with no prior FGA exposure.
So how does it actually look? What are these movements?
They're typically stereotyped, repetitive, involuntary movements. Often coriform, meaning kind of dance-like, you might see. Orofacial movements, grimacing, blinking, lip smacking, the tongue darting out, chewing motions, limb movements, fidgeting, writhing movements of arms or legs, trunk movements too. It can also manifest as tardive dystonia, sustained twisting, tardive akathisia, that restlessness, or rarely even pain. A key feature is that the movements usually stop during sleep and can fluctuate with arousal. It's often very distressing for the patient and can be stigmatizing.
It sounds awful. And treatment? Can it be reversed? It seems like it was historically very difficult.
It was incredibly difficult and often irreversible. Paradoxically, increasing the dose of a potent dopamine blocker could sometimes suppress the movements temporarily, but that likely worsens the underlying problem long term.
Right.
Switching to weaker D2 blockers generally doesn't help TD. The only exception was switching to clozapine, which can improve TD in some patients, but that's usually only an option if they need clozapine for other reasons, like treatment resistance.
But now there are those newer FDA-approved drugs, the VMAT2 inhibitors. Those sound like a real advance.
They have been a massive game changer for TD valbenazine and deutetrabenazine. They work by inhibiting VMAT2, which is a transporter protein that loads dopamine into vesicles before it gets released.
Okay.
By inhibiting VMAT2, they gently reduce the amount of dopamine released, which helps calm down those supersensitive D2 receptors without causing the harsh blockade of traditional antipsychotics.
More subtle approach.
Exactly. And they've been shown to be highly effective and generally well tolerated in clinical trials, with benefits lasting long term. If you stop the VMAT2 inhibitor, the TD symptoms usually come back, but while the patient is on it, it can make a huge difference. Valbenazine is once daily, deutetrabenazine is twice daily. They have different metabolic pathways, so you need to be aware of potential drug interactions. But overall, they represent a major step forward in managing this really debilitating side effect.
That's fantastic news for patients. Okay, what about akathisia? How is that different from the other movement issues, and how do you treat it?
Akathisia is distinct. It's this profound sense of inner restlessness, an inability to sit still, feeling like you need to crawl out of your skin. It's both subjective, the internal feeling, and objective position. You can often see the person pacing, shifting weight, fidgeting.
Right.
Really important not to mistake it for just anxiety or agitation. Usually starts within the first couple of months of treatment. And interestingly, it doesn't respond well to the anticholinergic drugs used for Parkinsonism, which suggests it involves pathways beyond the striatum.
So how do you manage it?
First steps are usually reducing the antipsychotic dose or switching to a lower-risk agent. For acute relief, high-potency benzodiazepines like clonazepam can help. Beta blockers that get into the brain well, like propranolol, are often very effective. And sometimes low-dose mirtazapine, which blocks 5-HT2A receptors, can also be useful.
Okay. And the most severe neurological reaction, neuroleptic malignant syndrome, NMS, That sounds like a true emergency.
It absolutely is. NMS is rare, but potentially fatal. Think of it like an extreme body-wide Parkinsonism plus a whole lot more.
Oh, boy.
You get extreme muscle rigidity, often called lead pipe rigidity, very high fever, unstable blood pressure, rapid heart rate, sweating autonomic instability, muscle breakdown products get released into the blood, myoglobinemia, which can damage the kidneys, and altered mental status, confusion, stupor, even coma.
Wow.
It can last for days or even weeks after stopping the drug and carries a real risk of death if not treated urgently. It's most often linked to high doses of potent D2 blockers or rapid dose increases.
And treatment.
Immediate stop of the antipsychotic. Aggressive supportive care, cooling blankets, IV fluids, and specific medications like bromocriptine, a dopamine agonist, or dantrolene, a muscle relaxant. Thankfully, it seems less common with the SGAs compared to the older FGAs, but you always have to be vigilant.
Truly frightening. Okay, let's talk about hyperprolactinemia. That seems common, affecting hormone levels.
Yeah, this happens because antipsychotics block D2 receptors in the pituitary gland. Normally, dopamine acts there to inhibit the release of prolactin.
Okay, dopamine is the brake.
Exactly. Block D2, you take the brake off, and prolactin levels go up. There's really good correlation.
Yeah.
The stronger the D2 blockade, the higher the prolactin elevation. Among the SGAs, amisulpride, risperidone, and its metabolite paliperidone are the biggest culprits. They seem to get concentrated in the pituitary gland because of a transporter protein called P-glycoprotein, leading to particularly high prolactin levels.
And what are the consequences of high prolactin? How do you manage it?
High prolactin can cause direct effects like breast enlargement or tenderness, galactorrhea, milk production, and missed periods in women, amenorrhea. In men, gynecomastia. And indirect effects, which are often very bothersome, like sexual dysfunction, low libido, erectile problems, and infertility in both sexes.
Right.
Management usually involves trying to lower the dose, but often the best approach is to switch the patient to a prolactin-sparing antipsychotic if possible. If switching isn't an option, you can sometimes add bromocriptine, the dopamine agonist, to lower prolactin directly. Prolactin levels usually normalize pretty quickly once the offending drug is stopped or switched. Interestingly, adding a partial agonist like aripiprazole isn't usually recommended and can sometimes paradoxically worsen it, likely by displacing the antagonist.
That's counterintuitive. Okay, shifting to histamine H1 receptors, we know they cause sedation, but they're also major players in weight gain, right?
Absolutely. Blocking H1 receptors centrally has two big consequences: sedation. Drugs with high H1 affinity like chlorpromazine, clozapine, quetiapine are very sedating. People often develop some tolerance to this over time, but if you stop these drugs suddenly, you get terrible rebound insomnia. So you have to taper them slowly.
Okay.
And weight gain. This is a massive issue for adherence and overall health. The main driver seems to be appetite stimulation via H1 blockade in the hypothalamus. Blocking 5-HT22C receptors might add to this effect for drugs that also block H1 strongly, like clozapine and olanzapine, but 5-HT2C blockade alone doesn't seem to cause much weight gain.
Right.
The highest risk agents are consistently chlorpromazine, olanzapine, quetiapine, and clozapine. Younger patients tend to be more sensitive to this effect.
Given how big a problem weight gain is, what can actually be done to manage it?
It requires active management. Switching to a more weight-neutral drug is often the best first step, if possible. If switching isn't feasible, then behavioral strategies, diet, exercise are crucial. Pharmacologically, metformin is commonly used, especially with olanzapine and clozapine, sometimes even started proactively. More recently, GLP-1 agonists like exenatide or liraglutide have shown promise.
Like the newer weight loss drug.
Exactly.
Yeah.
And there's that combination product approved in 2021, olanzapine plus samidorphan. Samidorphan blocks opioid receptors involved in the reward aspect of eating, aiming to specifically counteract olanzapine's weight gain effect. So targeted approaches are emerging.
Directly targeting appetite signals. Okay. What about muscarinic M1 receptors and the anticholinergic side effects?
M1 blockade causes those classic anticholinergic effects, both central, like confusion, memory problems, and peripheral, dry mouth, blurred vision, constipation, urinary retention. Most SGAs don't have strong M1 effects, but clozapine and the low-potency FGAs do. Clozapine, in particular, is notorious for causing severe constipation, sometimes even leading to bowel obstruction. This needs aggressive management with stool softeners and laxatives, but avoid psyllium, which can make it worse. And you absolutely want to avoid anticholinergic drugs in the elderly, especially those with dementia or delirium, because of the cognitive worsening, though clozapine might be used carefully if it's the only option for treatment resistance.
And alpha-1 adrenergic receptors causing orthostatic hypotension.
Right. Blocking alpha-1 receptors leads to that drop in blood pressure when standing up, causing dizziness or fainting. Big fall risk, especially in the elderly who might have poor vasomotor tone already.
Yeah.
Low-potency FGAs and allopurinol are higher risk. Allopurinol even has specific instructions for slow titration because of this. Clozapine can also cause significant orthostasis, sometimes managed with fludrocortisone to help expand blood volume if clozapine is essential.
Okay, so those are the effects tied pretty directly to specific receptor blockade. But what about the adverse effects that aren't so clearly predicted by these monoamine receptor interactions, like the major metabolic and cardiac issues?
Yeah, this is a huge area of concern, especially with long-term treatment. Metabolic problems can seriously impact overall health and lifespan. And remember, people with schizophrenia already start with a higher risk, double the rate of metabolic syndrome, type 2 diabetes, and cardiovascular death compared to the general population. Antipsychotics can unfortunately make this worse.
What are the main metabolic effects besides weight gain?
Two big ones. Dyslipidemia, especially high triglycerides. This is seen with low-potency FGAs and significantly with clozapine, olanzapine, and high-dose quetiapine. Often this happens even without major weight gain and can improve quickly if the drug is stopped. It's often a sign of insulin resistance. And hyperglycemia problems controlling blood sugar. This was first noticed with older drugs, but with SGAs, there have been many reports linking clozapine, olanzapine, and quetiapine to new-onset type 2 diabetes, even severe diabetic ketoacidosis. The exact mechanism isn't clear, but studies show these drugs can directly impair insulin sensitivity pretty quickly. While the illness itself contributes to metabolic risk, the choice of medication is definitely a major modifiable factor. All SGAs in the U.S. have warnings about hyperglycemia.
So monitoring is absolutely non-negotiable.
Absolutely essential. Guidelines strongly recommend getting baseline metabolic labs, fasting glucose or A1C, lipids, weight before starting any antipsychotic, plus a good personal and family history. And then ongoing monitoring is crucial. If problems arise, you need to reevaluate the treatment, push lifestyle changes, and seriously consider switching to a drug with a better metabolic profile.
Okay. Now, cardiac effects. This sounds potentially very serious. How do these drugs interfere with the heart, and what are the risks?
Some antipsychotics can mess with the heart's electrical system by interfering with ion channels, particularly potassium channels, like the IKR or HERG channel, and sometimes sodium channels. This can increase the risk of dangerous heart rhythms, ventricular arrhythmias, and even sudden cardiac death. Blocking that IKR channel, which is critical for resetting the heart muscle after a beat, is thought to be the main mechanism for most antipsychotic-related sudden deaths.
Which drugs are the main culprits?
Historically, thioridazine and pimozide were strongly linked to a specific dangerous rhythm called torsades de pointe and fatal arrhythmias. They have black box warnings. But it's reassuring that most of the commonly used newer SGAs are not associated with an increased risk of these ventricular arrhythmias. The old concern about clozapine causing QTc prolongation is now thought to be mostly an artifact of how it was measured in tachycardic patients. While most antipsychotics have a class warning about QTc prolongation, routine ECG screening just for that purpose isn't generally recommended unless the patient has other specific cardiac risk factors.
What about other heart effects? Specifically with clozapine again, it seems to have its own set of issues.
It does. Clozapine has some unique cardiac considerations. Tachycardia, a fast heart rate that's separate from orthostasis. Myocarditis, inflammation of the heart muscle. There's about a 1% risk, usually happening in the first 6 weeks of treatment. You diagnose it based on symptoms like chest pain or fatigue and elevated troponin or CRP levels. It's serious but rare.
Okay.
And less commonly, clozapine has been linked to dilated cardiomyopathy, where the heart muscle weakens and stretches.
That's a very specific risk profile for clozapine. Are there other significant, maybe less frequent side effects people should know about to achieve that mastery level?
Yes, a few others are important. Seizures. There's a class warning for seizure risk, usually 1%, for almost all antipsychotics except pimavanserin. Clozapine has a higher dose-dependent risk, around 3–5%. Olanzapine's risk is about 0.9%. If a patient has epilepsy, you need to ensure their anticonvulsant therapy is adequate and avoid anticonvulsants like carbamazepine or phenytoin that induce CYP enzymes and lower antipsychotic levels. Divalproex is often preferred for clozapine-related seizures.
Okay.
Severe neutropenia. This is clozapine's most feared side effect, that dangerous drop in neutrophils. The risk is under 1%, peaking around months 2–3. It's immune-mediated, and usually you don't re-challenge someone with clozapine if they develop it. Because it's so serious, there's mandatory strict blood monitoring, absolute neutrophil count, required by regulatory agencies. There are even updated guidelines to account for benign ethnic neutropenia.
Right, the RAMS program.
Exactly. And then less common things. Pigmentary retinopathy with thioridazine, photosensitivity, elevated liver enzymes, especially with low-potency phenolthiazines.
This really drives home the need for personalized treatment and close follow-up. And what about that increased mortality risk in dementia patients? That sounds significant and maybe not fully understood.
It's a major issue, and yes, still not fully understood. Numerous studies consistently show about a 1.7-fold increased risk of strokes and death from all causes, heart failure, sudden death, pneumonia, in elderly dementia patients taking antipsychotics compared to placebo.
Wow.
The cause isn't clear, but what's striking is that both FGAs and SGAs, even newer ones like epiduripiprazole, seem to carry a similar risk. This suggests it might be a broader consequence of reducing D2 signaling in these already vulnerable older patients, rather than something specific to one drug class's other actions.
That's very sobering. Okay, let's talk about drug interactions, DDIs, and special populations. How do antipsychotics interact with other meds, especially via those CYP liver enzymes?
Understanding DDIs is critical. CYP enzymes. Generally, antipsychotics aren't strong inhibitors of CYP enzymes, though there are exceptions. Chlorpromazine, perfenazine, thioridazine can inhibit CYP2D6. But antipsychotic levels themselves are heavily influenced by other drugs that induce or inhibit the CYPs that metabolize them. This, plus genetic variations in CYP enzymes, is why people can have vastly different drug levels on the same dose.
Right.
Protein binding. They are highly protein-bound, mostly to alpha-1 glycoproteins, but they usually don't bump other highly bound drugs like warfarin or anticonvulsants bound to albumin off their sites enough to cause problems. And they aren't removed by dialysis.
And environmental factors. I heard smoking is a huge issue, especially with clozapine.
Absolutely critical, especially for clozapine mastery. Tobacco smoke contains compounds that strongly induce CYP1A2, a major enzyme that breaks down clozapine.
Okay.
So if a patient on clozapine who smokes is admitted to a smoke-free hospital, their CYP1A2 activity drops, and their clozapine levels can shoot up, potentially becoming toxic. Conversely, if they're discharged and start smoking again, their CYP1A2 revs up, clozapine levels can drop by 50%, and they risk losing efficacy or relapsing.
So you have to constantly monitor levels around smoking changes.
Meticulously.
Yeah.
You need to anticipate these changes. And it's not just smoking serious infections like COVID-19 or even sometimes the vaccine can release cytokines that temporarily suppress CYP1A2, also leading to potential clozapine toxicity. Constant vigilance is key.
That's a level of detail that really highlights the complexity. Okay, special populations. What about kids and teens?
So several antipsychotics are FDA approved for use in pediatric populations. For adolescent schizophrenia, ages 13-17, drugs like aripiprazole, olanzapine, quetiapine, risperidone, lurasidone, paliperidone are approved.
Okay.
For acute mania in kids teens, 10-17, aripiprazole, quetiapine, risperidone are options, and lurasidone for bipolar depression in that age group. And for irritability linked to autism, ages 5-16, risperidone and aripiprazole are approved.
What are the main concerns in this age group?
Kids and teens, especially if they haven't taken these meds before, are generally more prone to EPS, and especially to weight gain than adults. So you want to use the lowest effective dose and try to pick agents with less weight gain potential. Monitoring for hyperprolactinemia is also important, especially with risperidone and paliperidone due to concerns about effects on sexual maturation. Metformin is often used alongside to help mitigate weight gain.
And for geriatric patients, how does their increased sensitivity affect choices?
In older adults, increased sensitivity often drives the choice. They're more susceptible to EPS, especially TD and Parkinsonism, orthostasis falls, sedation more falls, and anticholinergic effects confusion.
Right.
Avoiding drug interactions is also huge, as they're often on many other medications. You have to watch for additive effects like combining drugs that all cause sedation or have anticholinergic properties. Interestingly, though, antipsychotic-induced weight gain tends to be less severe in older adults compared to younger ones.
Finally, pregnancy and lactation. What are the key takeaways for these medications?
It's always a careful risk-benefit discussion. Pregnancy. Reassuringly, recent large studies haven't found an increased risk of major birth defects after first trimester exposure. That's lessened some earlier concerns.
Good to know.
However, these drugs do cross the placenta easily, so newborns can potentially experience withdrawal symptoms, sedation, or EPS right after birth. Floppy baby syndrome can happen with more sedating drugs like clozapine. For women with schizophrenia, continuing meds during pregnancy is usually recommended because relapse risk is high and dangerous. For other conditions, tapering off before delivery might be considered if it's safe for the mother.
And lactation. Breastfeeding.
This is tricky because newborns metabolize drugs poorly. There's a risk of toxicity from exposure through breast milk. Clozapine is an absolute no-go during breastfeeding because of the risk of neutropenia, sedation, and seizures in the infant. For other antipsychotics, it's a case-by-case decision, weighing the benefits of breastfeeding against the potential risks of infant exposure.
All right, we've thoroughly explored psychosis and the intricate world of antipsychotics. Let's pivot now to mania and bipolar disorder, starting right at the definition. What exactly is mania?
Right. Mania is defined clinically as a distinct period where someone's mood is abnormally and persistently elevated. Expansive meaning overly grand or optimistic or sometimes very irritable.
Okay.
And for it to be a manic episode, this mood change has to occur alongside several other symptoms, like a noticeable increase in energy or goal-directed activity, and critically, a decreased need for sleep. It's one pole of bipolar I disorder, characterized by significant impairment in functioning.
Can mania be triggered by things other than the underlying disorder, and how does that play into diagnosis?
Yes, it definitely can. Certain prescribed meds can induce mania, things like dopamine agonists for Parkinson's, sometimes antidepressants, stimulants, and substances of abuse, cocaine, amphetamines are well-known triggers. Now, just having substance-induced mania doesn't automatically mean someone has bipolar disorder. But here's the key distinction. If someone develops a full manic episode while taking an antidepressant, for example, and that episode continues even after the antidepressant's direct effects should have worn off, that is considered strong evidence for a true manic episode and a bipolar I diagnosis. It suggests an underlying vulnerability.
Got it. So how do we differentiate the different types of bipolar disorder? You mentioned bipolar I, but there's a spectrum, right?
Exactly. It's crucial to understand the spectrum. Mania versus hypomania. The main difference is severity. Hypomania is less severe. By definition, it doesn't cause major problems with work, school, or social life, and it doesn't lead to hospitalization. Mania always involves significant impairment or requires hospitalization.
Okay, severity is key.
Right. Then you have bipolar II disorder. These individuals have experienced periods of hypomania, but also full major depressive episodes.
Hypomania plus depression.
Correct. Bipolar I disorder means someone has had at least one full manic episode in their lifetime. They may or may not have had major depressive episodes, but the mania defines it.
Got it.
And then there's cyclothymia. This is for people with chronic, fluctuating moods, lots of periods with hypomanic symptoms and periods with depressive symptoms, but neither are severe enough to meet the full criteria for a major depressive or manic hypomanic episode.
Okay. How common are these?
Bipolar affects about 1% of the population, but if you include all forms bipolar I, II cyclothymia, it's probably closer to 3 to 5% lifetime prevalence. So quite common overall.
And are we making headway in understanding the genetics, like we discussed for schizophrenia? Can we predict who gets it or how they'll respond?
We are identifying genes linked to risk and maybe even treatment response through genetic studies. But we're not quite there yet in terms of using that information clinically, like predicting who will respond best to lithium based on their genes. And here's a really interesting contrast with schizophrenia. For schizophrenia, our understanding of dopamine led to designing drugs to target that system. But for bipolar disorder, we haven't yet designed a medication based on a complete biological hypothesis of the illness that treats the whole spectrum. Many of our best treatments were discovered more, well, serendipitously.
That's fascinating. Which brings us perfectly to lithium, a drug with a long, storied history, almost stumbled upon, right?
Lithium carbonate really is unique. Introduced by John Cade in Australia back in 1949, approved in the U.S. in 1970. And here's a remarkable thing, the point to really master. While lots of drugs work for acute mania lithium itself, antipsychotics, some anticonvulsants, no medication is proven better than lithium for preventing future manic antidepressive episodes in bipolar disorder.
Wow. Still the gold standard for prevention.
For prophylaxis, yes. It have unparalleled efficacy in maintaining long-term stability.
That's incredibly powerful. And it's not just preventing episodes, is it? There's another unique, incredibly important benefit.
Yes. Absolutely critical. No other medication has shown the same ability as lithium to reduce suicidality in people with bipolar disorder.
That's profound.
It truly is. It's a unique life-saving benefit. On top of that, there's a growing, compelling evidence that lithium has neuroprotective effects. It seems to lower the risk of dementia in older bipolar patients on long-term treatment. It's being looked at for potential benefits in other neurodegenerative conditions too, so its impact goes well beyond just mood.
Okay, let's dive into how it works. It's just a simple element, but its actions seem incredibly complex. What are its basic properties, and how does it affect ion transport in the brain?
Yeah, it's fascinating. Lithium is the lightest alkali metal, chemically similar to sodium and potassium. We can easily measure it in the blood and even track it in the brain with techniques like MRS. It doesn't have any known natural role in the body, but therapeutically, we use lithium carbonate or citrate. What's really interesting is that at therapeutic levels, usually zero point 0.6 to 1.0 MEQL, it has almost no noticeable effect on someone without a psychiatric condition. It seems to mainly act when there's an underlying mood imbalance. Regarding ion transport, lithium doesn't build up a strong concentration gradient across cell membranes, like sodium or potassium do. It can substitute for sodium to allow a single nerve impulse, a single action potential,
Okay.
but it can't be pumped out efficiently by the sodium pump, so it can't maintain the cell's electrical potential long term. It's still a bit unclear if it significantly affects the transport of other ions at therapeutic doses.
What about its effects on neurotransmitters like monoamines and those complex signaling pathways inside the cell? That seems to be where the real action is.
That's where the main hypotheses lie. Lithium seems to impact
Mm-hmm.
monoamines. While it doesn't directly bind strongly to receptors or drastically change overall levels, it does subtly influence serotonin systems. It seems to affect serotonin autoreceptors and boost serotonin release presynaptically.
Right.
And second messenger systems. This is where the most compelling evidence is. Lithium profoundly affects intracellular signaling cascades, gene expression, even cell survival pathways. It seems to potentiate antidepressant effects, possibly by desensitizing certain serotonin receptors like 5-HT1B.
I read about its major effect on the phosphatidylinositol, or PI, pathway, specifically inhibiting an enzyme called inositol monophosphatase. Can you really break that down for us? It sounds fundamental.
Yes, this is considered a core mechanism, really deep cellular biology. Lithium directly inhibits inositol monophosphatase, IMPAS. This enzyme is crucial for recycling inositol within the phosphatidylinositol PI pathway.
Okay, the PI pathway.
Think of the PI pathway as a major internal communication network in neurons. It generates second messengers like IP3 and DAGI that relay signals from receptors on the surface deeper into the cell.
Got it.
So when lithium inhibits IMPAS, two key things happen. One, it can lead to an accumulation of IP3 when that pathway is active. This boosts calcium release inside the cell and activates another enzyme called protein kinase C, PKC. Two, and perhaps more importantly, it leads to a decrease in free inositol. Inositol is essential for rebuilding the components of the PI pathway in the cell membrane. By depleting inositol, lithium effectively dampens down an overactive PI signaling system.
Like turning down the volume on an overactive cellular comms system.
Exactly. And this inhibition happens right within the therapeutic range for lithium. What makes this even more compelling is that genetic studies have linked another enzyme in this pathway, diacylglycerol kinase, to bipolar disorder risk. And interestingly, other mood stabilizers like valproic acid, VPA, and carbamazepine also decrease intracellular inositol levels, although they do it through different mechanisms. This convergence suggests the PI pathway might be a common target for mood stabilization.
So acting like a reset switch for overactive brain signaling. You mentioned protein kinase C, PKC gets activated initially, but lithium ultimately decreases its activity. How does that work?
Right, it's a downstream effect. Long-term lithium treatment leads to decreased activity of several protein kinases, notably PKC, especially the alpha and beta types. And importantly, VPA does this too, but carbamazepine doesn't.
Interesting.
Lithium seems to prevent PKC from moving to the cell membrane where it needs to act. This is significant because overactive PKC can disrupt how the prefrontal cortex regulates behavior, emotion, and impulses, things often affected in mania. Lithium and VPA can actually block memory problems caused by activating PKC.
Okay.
There's a key protein called MRCKS that PKC acts on, involved in brain plasticity. Both lithium and VPA reduce MRCKS expression, but other drugs don't. This whole PKC inhibition idea even led to trials using tamoxifen, the breast cancer drug, as an add-on for mania, because tamoxifen also inhibits PKC in the brain.
Wow, connecting those dots is amazing. What about glycogen synthase kinase 3 beta, GSK3 beta, another key enzyme?
Yes, another major target. Both lithium and VPA inhibit GSK3 beta. This is important because inhibiting GSK3 beta increases levels of another protein called beta-catenin in the hippocampus, and beta-catenin seems to be crucial for mood stabilization. Okay. Animal studies show that lithium mimics the effects of genetically knocking out one copy of the GSK3 beta gene. Mechanistically, lithium messes with a signaling complex involving beta-arrestin 2 and ACT. By disrupting this complex, lithium keeps ACT active, and active ACT then phosphorylates and inhibits GSK3 beta. It's another molecular cascade leading towards mood stabilization.
So multiple complex pathways converging, and there was something about arachidonic acid turnover too.
Yeah, another potential shared mechanism between lithium and VPA is reducing the turnover of arachidonic acid in brain cell membranes. Arachidonic acid is involved in inflammation and signaling. Studies show lithium reduces the expression of enzymes like phospholipase A2, which releases arachidonic acid, and COX2 involved in inflammation. This suggests lithium might have anti-inflammatory or membrane-stabilizing effects that contribute to its overall action.
That's a stunning amount of molecular detail. Okay, let's get practical. Lithium's pharmacokinetics, dosing, monitoring, super important given its narrow therapeutic window. How is it absorbed and distributed?
Absolutely critical for safe use. Absorption. Lithium is absorbed really well from the gut, almost completely. Peak blood levels happen about 2-4 hours after taking it. But importantly, peak brain levels lag behind, maybe by another 3 hours or so.
Okay, distribution.
It first spreads out in the extracellular fluid. It doesn't bind much to proteins in the blood, so most of it's free and active. Then it slowly accumulates in tissues. It crosses the blood-brain barrier slowly, reaching about 40–50% of the blood level at steady state. We can actually use MRS scans to see lithium levels in the human brain, which is cool for research.
And elimination. I heard once daily dosing is better for the kidneys.
Right. About 95% gets eliminated unchanged by the kidneys. So kidney function is paramount. The half-life in the blood is roughly 24 hours shorter in younger folks, longer in the elderly because kidney function declines with age. The half-life in the brain is longer, around 28 hours, which strongly supports once daily dosing.
Why is once daily better?
This is a key practical point for achieving mastery here. Giving the entire dose once a day, usually at night, significantly reduces the long-term risk of kidney problems by at least 20% compared to splitting the dose.
Wow, 20%.
Yeah, it minimizes how long the kidneys are exposed to peak lithium levels. Plus, it improves adherence, and because the peak blood level happens while the person is asleep, it minimizes daytime side effects like tremor or incoordination.
That's a huge clinical pearl. And the competition with sodium, how does that create risks?
This is vital for avoiding toxicity. Lithium and sodium compete for reabsorption in the kidney tubules. So anything that makes the body lose sodium can cause the kidneys to hold on to more lithium, potentially pushing levels into the toxic range.
Like what?
Things like using thiazide diuretics, having severe diarrhea or vomiting, or sweating heavily and only replacing fluids with plain water without enough salt. In those situations, the body tries harder to conserve sodium. And because lithium looks similar to sodium to the kidneys, it reabsorbs more lithium too. Levels can rise quickly and dangerously.
Definitely highlights the need for careful monitoring. What are the target blood levels for lithium, and how do they differ for acute mania versus long-term prevention?
Monitoring is non-negotiable because of that narrow therapeutic index. Effective and safe levels generally fall between 0.6 and 1.5 millieql.
Okay.
For acute mania, you often aim a bit higher, maybe 1.0 to 1.5 millieql to get symptoms under control.
Right.
For long-term prevention or prophylaxis, lower levels are safer, typically 0.6 to 1.0 millieql. Crucially, keeping levels consistently below 1.2 millieql long-term is important to minimize the risk of kidney damage. There's a clear dose response. Higher levels work better, especially for mania prevention like 0.8, 1.0, but they also cause more side effects like tremor and polyuria, excessive urination. So you have to individualize the target level, find the sweet spot for each patient. Some do find long-term at lower levels like 0.5, 0.8.
And when should the blood draw happen for accurate monitoring?
The standard practice is to measure the serum level 10 to 12 hours after the last dose, usually the evening dose. This gives you a trough level, the lowest point before the next dose, which is the most reliable guide for long-term adjustments. Even though once daily dosing causes bigger swings in blood levels, higher peaks, lower troughs, it actually results in lower average trough levels and minimizes those peak-related CNS side effects. Delayed release forms can help with stomach upset and are also usually given once daily at night.
Okay, let's talk therapeutic uses in practice. Who's a good candidate for lithium, and what are its official FDA-approved indications?
Ideally, you start lithium in someone with good kidney function. An eGFR over 70 milliomin is a common benchmark. But sometimes, the need is so compelling that you might use it cautiously, even with other health issues, though managing multiple meds can get tricky. The FDA has approved it for two main things: treating acute mania in adults and adolescents,
Okay.
and preventing recurrences, both mania and depression and bipolar illness, again in adults and adolescents.
And beyond those official uses, what other major benefits does lithium have that make it stand out?
This is where lithium really shows its unique value: suicide risk reduction. We mentioned it, but it bears repeating. Lithium has the strongest evidence by far for reducing suicidality in bipolar disorder, and this effect carries over to unipolar depression too when added to an antidepressant. It's linked to a 5-fold reduction in suicide attempts compared to other treatments. That's massive.
Truly life-saving.
And neuroprotection. The data is getting stronger. Long-term lithium use is linked to a 50% lower risk of dementia in older bipolar patients, sometimes kicking in after just a year of treatment. Based on animal studies and emerging human data, people are even exploring it for conditions involving nerve cell death like stroke, spinal cord injury, and neurodegenerative diseases like Alzheimer's, Parkinson's, Huntington's, ALS. It seems to protect brain cells.
So, a powerful, multifaceted drug. How is mania actually treated in practice? Are these mood stabilizers used alone or often combined?
In practice today, while lithium, VPA, and carbamazepine are all effective for acute mania, they're often combined with an atypical antipsychotic right from the start, even if the patient isn't psychotic.
Why combine?
They have complementary mechanisms, so the combination often brings broader and faster symptom control. The mood stabilizers need daily dosing and blood monitoring, but acutely manic patients can be really difficult: irritable, agitated, refusing meds or blood draws.
Right.
So sometimes an atypical antipsychotic might be the only thing you can get into them initially, especially via injection, to get rapid control while you work on starting the mood stabilizer.
And for lithium specifically, how do you use loading doses to get levels up quickly in acute mania?
You can load lithium in patients with good kidneys to get therapeutic levels faster. A common way is using a sustained release form, giving 3 doses based on body weight, 10 millikilogram each, a couple of hours apart in the evening.
Okay.
Given lithium's long half-life in the brain, around 28 hours, there's really no need for split daily dosing long-term, unless maybe for GI side effects. You often need higher doses initially in mania, then reduce them once the mood stabilizes. You can often see effects within 5 days with loading. Liquid lithium citrate is also an option if pills are hard.
What about valproic acid or divalproex for acute mania? How does that compare?
Valproic acid, usually given as divalproic sodium, which is better tolerated, is also very effective for mania, often working within 3 to 5 days if loaded properly. Loading is typically around 30 millibikilograms over the first 24 hours, then adjusted based on trough levels, aiming for 90, 120 in GDL. A big plus is it doesn't have the kidney or thyroid risks of lithium.
But downsides?
Yes, major ones, especially for women of childbearing potential. There's a link to polycystic ovary syndrome, PCOS, and crucially, it's highly teratogenic, causes birth defects. So effective contraception is an absolute must. Other potential issues include high ammonia levels, low platelets, and low white blood cell counts.
And carbamazepine, another anticonvulsant option.
Carbamazepine works for acute mania and maintenance too, but you can't load it quickly because of side effects like dizziness and ataxia that pop up fast, even in the therapeutic range.
Okay.
Its response rates in acute mania are generally a bit lower than lithium or VPA, maybe 45–60%, but some people respond really well when the others haven't worked. The critical thing with carbamazepine is screening patients of Asian ancestry for the HLA-B-Phin02 gene variant before starting.
Why is that?
Because that gene variant dramatically increases the risk of potentially fatal skin reactions like Stevens-Johnson syndrome. It's a crucial safety check.
Absolutely. And lamotrigine, often grouped with these, but you said no role in acute mania?
Correct. 0 role in acute mania. That's because you have to titrate it up very slowly over weeks to minimize the risk of that same serious rash, Stevens-Johnson syndrome.
Ah, the slow titration prevents acute use.
Exactly. Its real value, and it's significant, is in bipolar maintenance, particularly in preventing or treating the depressive episodes, which is vital because bipolar patients spend a lot of time depressed. But that antidepressant effect takes time to kick in because of the slow start.
Okay, so for long-term prevention, prophylaxis, what guides the choice between these options? And how do monotherapy and combination therapies stack up?
It's complex. The choice depends on whether the patient still needs an antipsychotic ongoingly, plus a primary mood stabilizer. Some SGAs like aripiprazole or olanzapine can work as monotherapy for mania prevention, but olanzapine has metabolic issues, and aripiprazole doesn't help prevent depression. Real-world data strongly suggests that patients on antipsychotic monotherapy tend to relapse more often than those on lithium monotherapy.
Okay.
The lowest relapse rates for bipolar I are consistently seen in patients on combination therapy, a mood stabilizer like lithium or VPA, plus an antipsychotic. While many do well on monotherapy, the combo often offers the best protection.
And what are the biggest ongoing concerns during treatment, especially around relapse and suicide risk?
The huge recurrence rate is the overriding concern, plus the tragically high suicide risk. Someone with one manic episode has an 80–90% chance of having another. And just like in schizophrenia, poor insight, lack of support, substance abuse, they all sabotage adherence and increase relapse. Now, while anticonvulsants like lamotrigine, carbamazepine, and VPA help with prophylaxis, it's critical to remember only lithium has consistently shown that reduction in suicide risk compared to other bipolar treatments. That makes it foundational for many. Lamotrigine is particularly good for preventing depressive relapse, as we said.
And lamotrigine had that recent FDA warning about heart risks.
Yes, March 2021. The FDA warned it could slow heart conduction and cause arrhythmias, potentially fatal ones, in people with pre-existing heart conditions. Conduction problems, heart failure, structural heart disease, Brugada syndrome, other channelopathies.
Because it acts like an antiarrhythmic itself.
Exactly. It has class IB antiarrhythmic properties, so you have to be cautious using it with other sodium channel blockers too, a crucial study update.
Definitely. What about stopping mood stabilizers? It sounds incredibly risky, especially with lithium.
It is a very high-stakes decision. Bipolar disorder is usually a lifelong illness. Stopping treatment needs careful thought. Maybe after a single manic episode with a clear trigger that's gone, or maybe in a milder bipolar 2, but it's always a risk-benefit calculation.
And lithium especially.
Yes. Stopping lithium abruptly, particularly in bipolar I, carries a very high risk of early relapse, often much quicker and more severe than the natural course of the illness, and increased suicidal behavior for several months afterward.
A rebound effect.
It seems like it. So if you're going to stop lithium, it absolutely must be tapered slowly, gradually, over weeks or even months. Never stop it suddenly unless it's a dire medical emergency.
Okay, we've covered the remarkable benefits and uses of lithium and other mood stabilizers. Now, let's dive into their specific adverse effects, starting with lithium's impact on the central nervous system.
Right. Managing lithium effectively means knowing its side effect profile well. The most common CNS effect is that fine postural hand tremor.
Okay.
It's just like a central tremor. It's dose and level dependent, affecting anywhere from 15% to maybe 70% of patients. Avoiding caffeine can help. If it's bothersome, you might try reducing the dose, carefully balancing that against relapse risk. Beta blockers like propranolol work well for managing it too, and also for VPA-induced tremor. At peak levels, especially if dosing isn't at night, people might feel uncoordinated ataxic or have slurred speech. Bedtime dosing usually avoids this.
And seizures, I thought that was rare, but possible.
It is rare, but seizures have been reported even at therapeutic lithium levels in people without epilepsy. Lithium can also increase confusion after ECT, so it's often tapered off before ECT if possible. Sometimes adding lithium to an antipsychotic can make someone more sensitive to EPS. And then there's weight gain, which can definitely happen with lithium, and is often made worse if someone is also taking an antipsychotic known for causing weight gain. Metformin might be considered to help mitigate this.
Okay. Now, the renal effects, especially nephrogenic diabetes, insipidus, NDI, this sounds like a potentially serious long-term issue.
It is a major one. Lithium significantly affects the kidney's ability to concentrate urine. About 60% of people on lithium develop some degree of polyuria, making lots of urine, often over 3 liters a day, and polydipsia, being constantly thirsty.
And the mechanism, how does lithium cause this?
It gets into the cells of the distal tubules in the kidney through a sodium channel called ENaC, which it actually has a higher affinity for than sodium itself.
Well,
once inside, high lithium levels inhibit that enzyme GSK3 beta we talked about. This makes the kidney cells less responsive to vasopressin, the antidiuretic hormone, and leads to fewer aquaporin-2 water channels on the cell surface. Aquaporins are needed to reabsorb water back into the body.
So the kidneys can't hold onto water properly.
Exactly, leading to NDI. And critically, taking lithium multiple times a day increases this risk by at least 20% compared to taking it all at once at night, because it keeps kidney cell exposure high.
So how do you monitor for NDI and prevent serious kidney damage?
Vigilant monitoring is key. You need regular kidney function tests, BUN, and creatinine to calculate eGFR, maybe twice a year. And checking urine osmolality periodically helps track concentrating ability. Ask patients directly about excessive urination or thirst.
And management.
If NDI develops early, stopping lithium or switching to once daily dosing might reverse it, especially if exposure is less than 5 years. But the preferred treatment is usually amiloride, a potassium-sparing diuretic.
How does amiloride help?
It specifically blocks lithium from entering those kidney tubule cells via the ENSC channel, prevents the buildup inside the cell. You do need to monitor electrolytes carefully with amiloride, as it can affect sodium and potassium.
Okay. When do you absolutely need to rethink or stop lithium due to kidney issues?
You should reassess if the eGFR consistently drops below 60, if urine output stays over 4 liters a day, or if creatinine keeps climbing on multiple checks. Discontinuation is generally advised if eGFR persistently falls below 50 to prevent toxicity and further decline. With good monitoring, though, lithium shouldn't cause severe chronic kidney disease requiring dialysis anymore.
That's good to hear. What about thyroid effects and other endocrine issues with lithium?
Lithium can definitely affect the thyroid. Some people get a benign, painless enlargement of the thyroid gland. More concretely, overt hypothyroidism occurs in 7–10% of patients,
Okay.
and subclinical thyroid problems in maybe 23%. Women are much higher risk than men.
So monitoring is needed.
Yes, baseline and annual TSH and free thyroxine levels are recommended. But if hypothyroidism develops, it's easily treated with thyroid hormone replacement. It's not a reason to stop lithium, given lithium's benefits. Hypothyroidism is rare but possible. Also, watch for hypercalcemia, high calcium, due to effects on the parathyroid gland. Happens in about 10% of patients, so check calcium levels regularly too.
And ECG effects. Does it impact heart rhythm?
It can cause ECG changes. It inhibits sodium channels in heart muscle and lowers intercellular potassium. The most common change is T-wave depression or flattening.
Okay.
It can also cause sinus node dysfunction, slow heart rate, or slow conduction. Rarely, it might unmask underlying conditions like Brugada syndrome. Significant heart problems usually only happen at toxic levels, over 1.5 milli-UQL. Routine ECGs might be wise for older patients or those with known heart issues, but not necessarily for everyone.
Okay. What about skin problems with lithium?
It can cause various skin issues. Allergic reactions like rashes or vasculitis. It often worsens pre-existing acne or psoriasis. These might need topical treatment, or sometimes only improve if lithium is stopped. And alopecia, or hair loss, affects 10–12% of people on lithium, similar to VPA, actually. There might be a link to that GSK3 beta-beta catenin pathway. Multivitamins with selenium and zinc, or topical monoxidil might help sometimes.
Let's quickly revisit pregnancy and lactation for lithium specifically. What are the key points there?
Pregnancy. There's that slight increase in the risk of a rare heart defect, Epstein anomaly, with first trimester exposure. It's a small absolute risk, but needs to be weighed against the high risk of relapse if a bipolar I patient stops lithium. Careful screening ultrasounds are recommended if lithium is continued. Antipsychotics or ECT might be alternatives during the first trimester if needed.
Okay. And newborn's lactation.
Lithium crosses the placenta, so newborns can have temporary issues like low muscle tone, floppy baby, CNS depression or goiter, even if maternal levels are therapeutic. Withholding lithium for 24 or 48 hours before delivery is often recommended to avoid toxicity as fluid shifts occur postpartum. These neonatal effects are usually reversible. Breastfeeding is generally discouraged due to infant exposure and toxicity risk, as newborns clear it poorly.
Any other less common lithium effects?
Yeah, it often causes a benign increase in white blood cell count, neutrophils, due to stimulating G-CSF, and some people report a metallic taste.
Okay, it definitely demands respect. What about acute toxicity or overdose? How does that look?
Toxicity severity depends on the level and how fast it rises. Acute intoxication can cause severe vomiting, diarrhea, coarse tremor, ataxia, confusion leading to coma, and seizures. Milder toxicity might just be nausea, maybe some fine tremor or sedation, often right after a dose. The really dangerous effects are neurological confusion, hyperreflexia, gross tremor, slurred speech, seizures, coma, sometimes irreversible brain damage. Cerebellar tremor can be permanent. Cardiac arrhythmias and low blood pressure can also occur.
Is there an antidote? How is it treated?
No specific antidote, unfortunately. Treatment is supportive manage airway, monitor heart. Admission is usually needed if levels are over 2 milli-EQL, even without symptoms. Correcting dehydration and sodium imbalance is crucial. Remember, blood levels don't always match brain toxicity perfectly, as brain levels lag.
And the main treatment for severe cases?
Dialysis. It's the most effective way to remove lithium quickly from the body and brain. It's definitely indicated if levels are really high, like 5.2 milli-QL, or if kidney function is poor, creatinine 2.26 milli-GDL, or the patient has severe neurological symptoms even at lower levels. Prognosis is tied to peak levels, full recovery is typical around 2.5, permanent neurological issues around 3.2, and risk of death around 4.2. It's a serious situation.
Very serious. Okay, let's briefly hit the key adverse effects for the other main mood stabilizers. Valproic acid, carbamazepine, lamotrigine that elite professionals need to know.
Right, valproic acid, VPI to valproex. Besides efficacy, remember weight gain, tremor, hyperammonemia, especially risky urea cycle disorders, low platelets, low neutrophils, and the absolute critical concerns for women, PCOS risk, and high teratogenicity requiring contraception.
Got it. Carbamazepine.
Effective. But remember the HLA-B1502 screening in Asian patients for Stevens-Johnson risk. Other issues include low sodium, hyponatremia, low white blood cells, leukopenia, and it's a potent inducer of liver enzymes, especially CYP3A4 and PGP. This means it can lower the levels of many other drugs the patient takes.
Big interaction potential. Lamotrigine.
Great for bipolar depression maintenance. Key issues are the slow titration needed to avoid Stevens-Johnson rash, so no acute mania use, and that recent FDA warning about arrhythmia risk in patients with pre-existing cardiac disease due to its sodium channel blocking effects. Avoid in patients with conduction issues, heart failure, Brugada, etc.
Okay, bringing it all together strategically. What's the relapse risk reality and what messes with adherence?
Reality is, relapse risk is incredibly high in bipolar disorder, 80–90% lifetime risk of another manic episode after the first one. Things that interfere with adherence are similar to schizophrenia. Poor insight, lack of support, substance abuse, all major challenges.
So how do you optimize treatment? Monotherapy or combination for the long haul?
As we discussed, the data points towards combination therapy, a mood stabilizer, plus an antipsychotic offering the lowest relapse rates for bipolar I, although many patients do well on mood stabilizer monotherapy. It's about finding the right balance for the individual.
And deciding to stop. Always risky.
Very risky, especially for bipolar I. Careful consideration needed maybe after a single triggered episode, maybe in milder bipolar II. But rapid discontinuation of lithium is particularly dangerous, linked to early recurrence and suicidality. If stopping is necessary, it must be a slow, gradual taper.
And finally, geriatric considerations for mood stabilizers.
Older adults can tolerate lithium well if their kidneys are okay, eGFR 70, and might benefit from its neuroprotection. But drug interactions are a bigger concern due to polypharmacy. You generally aim for lower maintenance levels, 0.60, 0.8 mEq due to slower clearance. Consider alternatives if eGFR drops below 50, and they're more sensitive to CNS side effects, confusion, ataxia, sedation, EPS, so start low, go slow.
Wow. We have truly covered an immense and intricate landscape today. From the deep mechanisms of psychosis and mania to the sophisticated actions and risks of antipsychotics and mood stabilizers.
Absolutely. We've navigated the incredible complexity, the constantly evolving science. It really highlights how far pharmacotherapy has come in improving lives, while also underscoring that critical need for meticulous monitoring, individualization, and a deep understanding of the potential downsides. It's where the science truly meets the art of clinical practice.
It really is. This deep dive, I hope, has equipped you, our listener, with that professional level mastery, that ability to see the layers, the nuances, the balancing act involved. So thinking ahead, given all this progress in brain chemistry and drug action, what breakthroughs do you imagine might really reshape mental health treatment in the next decade? Where are we heading towards even greater precision?
That's the million-dollar question, isn't it?
Yeah.
I think diagnostics will become huge. Imagine reliable biomarkers, blood tests, maybe specific brain imaging patterns that could predict who will respond best to which drug before you even start treatment. Moving beyond trial and error would be transformative. And the trend towards more specific targets like pimavanserin hitting just 5-HT2A or exploring TAR1 or M4 agonism suggests a future with potentially more targeted therapies, maybe with fewer off-target side effects. Getting deeper into the genetics of treatment resistance could also unlock truly personalized approaches, tailoring treatments to an individual's unique biology. It's all about moving from broad strokes to fine-tuned interventions.
That future sounds incredible. Preempting side effects, knowing which drug will work. It really underscores how dynamic this field is and how much mastery is still needed to truly understand the brain.
Precisely. It's an ongoing journey, but one filled with immense hope.
We hope this deep dive has given you a solid foundation for that mastery, empowering you with knowledge. Keep exploring, keep questioning these vital topics. We'll see you next time on The Deep Dive.